Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta, medical editor at MIMS Learning. Joining me in the studio today is Pat, editor of MIMS Learning.
Hello.
At MIMS Learning, we bring together curated collections of learning modules into what we call learning plans. We've just launched a whole new set of learning plans, drawing together CPD in related areas, adding to the ones we already have. These fit with the GP's personal development plans, in which they nominate particular areas where they have identified learning needs. You can get between 4 and 10 hours of CPD for an individual plan, depending on its length. Today, I'd like to talk about the Infant and Child Nutrition Learning Plan. These modules discuss a range of feeding, nutritional, and gastroenterology problems a GP might encounter in a pediatric population.
The early months of a baby's life are life-changing for the parents, and they're often fraught with worries about feeding.
Yes, these problems crop up fairly often, and parents can understandably become very anxious if their child refuses to feed or doesn't eat as much as expected.
Fluctuations in appetite, periods of fussiness, brief feeding refusals, and changes in feeding patterns can all be typical and expected behaviours in an infant. In the early months, these feeding concerns are a part of normal infant behaviour and will often resolve spontaneously.
Parental anxiety around these feeding problems is completely understandable. That said, it can sometimes make things worse. Well-meaning attempts by parents to encourage their child to eat by overfeeding or pressuring the child can lead to tension around meal times. Another technique that parents resort to is using distractions while an infant is feeding. These strategies can make it harder for the infants to learn about self-regulation and can lead to problems later on in life. Some feeding difficulties are more persistent or complex, and clinicians should be able to identify when they fall outside the range of normal to ensure that families get timely support. In a module on feeding problems in infants, Dr. Pippin Singh talks about how feeding problems can present clinically as vomiting or posseting, suspected food allergy or intolerance, poor weight gain, and difficulties transitioning to solids during weaning. Pat, can you remind us of some of the common causes of these feeding difficulties?
Yes, reflux is a very common one. It's thought to affect around 4 in 10 babies. Gastro-oesophageal reflux, or GOR, is normal in infancy and often resolves by itself in the majority of cases. It's called gastro-oesophageal reflux disease, or GORD, when it's associated with one or more additional symptoms.
In the module we have on the NICE Guidelines on GORD in Children by Dr. Tasneem Kapasi, she writes that most common additional symptom that tips GOR into GORD in infants is marked distress. The NICE guidelines quantify this distress as a visible demonstration of pain or unhappiness that falls outside of what is considered normal by a healthcare professional. The module looks at the case of Mary, who brings her 10-week-old Emily to the surgery. Emily was born prematurely at 33 weeks and is bottle-fed. Mary expresses worry about Emily vomiting after every bottle, sometimes regurgitating up to half of her feed. However, Emily is not distressed, appears content, her weight is stable, and she produces appropriate wet and dirty nappies.
In this case, Emily has symptoms of GOR, but without additional symptoms like marked distress or weight faltering, she would not be classified as having GORD. Mary needs reassurance that this is a normal physiological phenomenon and support and feeding advice, and education on red flag symptoms. Sangeeta, could you talk us through some of the red flag symptoms associated with GORD?
Bile-stained vomiting, hematemesis, an increase in distress, growth concerns, and if the vomiting becomes increasingly projectile in nature, are all red flag symptoms that would warrant an urgent referral to secondary care. Clinicians should also consider the differentials for vomiting with distress, such as pyloric stenosis, intestinal obstruction, urinary tract infections, or even raised intracranial pressure, which would warrant a neurological examination. Pat, what are some management options for GORD?
NICE guidance offers a very clear stepwise approach for a child with GORD. Infants must always be put to sleep on their backs, even if they have reflux symptoms, and this is in line with guidance around sudden infant death syndrome. For formula-fed babies, the next step can be to reduce the volume of feeds while increasing the frequency. Thickened formulas may also be trialled to alleviate symptoms before even considering pharmacological treatments. If these feeding adjustments don't help to improve symptoms, alginate therapy may be considered for 1 to 2 weeks. and the effects should be periodically monitored to avoid unnecessary long-term use. If alginates fail, clinicians can consider a 4-week trial of either proton pump inhibitors or H2 receptor antagonist therapy. NICE does not dictate which medication to use first. The decision should be based on the child's age, parental choice, and local procurement costs.
Yeah, and what not to do is also worth a mention here. The guidance does not recommend medications like metoclopramide, domperidone, or erythromycin. Also, historically, clinicians might have attributed unexplained distress and crying in infants to silent reflux and treated it as such. The current guidelines advise against this approach. If a child has marked distress but no visible regurgitation, they should not be investigated or treated for GORD.
Well, that's interesting. And a final note about GORD, it affects older children too, and the presentation is quite different from that in infants. So older children might complain of dyspepsia, retrosternal pain, or epigastric pain. The condition is less likely to be self-limiting in older children, so clinicians have to watch out for longer-term consequences like recurrent aspiration pneumonia and dental erosions. Children with neurodisabilities like cerebral palsy are especially vulnerable to dental issues, and esophageal pH studies are recommended for them. Interestingly, GORD may contribute to recurrent childhood otitis media, and studies have shown that treating the GORD can decrease the number of episodes of ear infection in children.
That's interesting.
It is. Moving on, it would be remiss to discuss feeding problems and not consider cow's milk allergy, or CMA, which is an important differential in an infant who presents with vomiting and distress. CMA is the most common food allergy in infants, affecting around 2 to 3% of infants worldwide. The symptoms of CMA can overlap heavily with GORD, but a careful history of the presenting complaint can help distinguish the two. The presence of diarrhea, with or without blood, for instance, is much more suggestive of CMA than of GORD.
Yeah, and the diagnosis of CMA is primarily clinical and centers around a detailed allergy-focused history. CMA reactions can be IgE mediated, which are immediate, or non-IgE mediated, which are delayed. To confirm non-IgE CMA, milk protein must be eliminated and then reintroduced under clinical supervision. If an IgE-mediated CMA is suspected, a referral to specialist allergy services is required for an IgE blood test, skin prick testing, or an oral food challenge. Throughout this journey, dietetic support is essential to ensure nutritional adequacy and timely reintroduction if needed.
Constipation is another frequent cause of feeding issues, and it can also be a consequence of feeding difficulties. Babies who are constipated experience discomfort, pain, or bloating, which leads to fussiness when feeding and a reduction in intake. Constipation in younger babies can be linked to inadequate fluid intake or formula composition, and it often appears transiently when weaning commences. Simple strategies like leg cycling, light stomach massage, or in older infants giving a small amount of cool boiled water or offering pureed prunes can help.
Moving on from constipation, sometimes infants who have experienced pain during feeding due to reflux, allergy, or oral trauma might develop an aversion. Sensory sensitivities are particularly common in neurodivergent children or in those with delayed development. It's worth remembering that children with sensory concerns around eating are not fussy eaters. Children with this condition would benefit from a multidisciplinary approach involving dietetics, speech and language therapy, and occupational therapy.
Let's take a more zoomed out look at the overall nutritional status of a child. Malnutrition is an under-recognised condition in the UK because it doesn't always present as obvious wasting. The World Health Organization defines malnutrition as deficiencies, excesses, or imbalances in a person's intake of energy and nutrients. So this might come as a surprise, but malnutrition can actually apply to children living with obesity, whose dietary quality is poor despite the fact there is an excess of energy. Specialist paediatric dietitian Hannah Whitaker discusses this topic in depth in her module on malnutrition in children. So Sagita, how would a clinician identify malnutrition, especially when it doesn't appear as obvious wasting?
In primary care, a clinician should look out for signs like persistent fatigue, pallor, frequent infections, delayed wound healing, and dental issues. A blood test can be used to confirm issues like iron deficiency or conditions such as celiac disease. Once identified, nutrient deficiencies can be addressed with a corrective loading dose of supplements before maintaining nutritional status through diet. What could cause such malnutrition, Pat?
Well, the module lists 3 important drivers, which are dietary, disease-related, and behavioural drivers. So first, on the dietary side, the ubiquity of ultra-processed foods is one of the drivers of malnutrition. In the UK, ultra-processed foods contribute to over 60% of the daily energy intake for children aged 7. These foods are typically high in calories, sugar and salt, but lack protein, fibre and essential micronutrients, directly contributing to micronutrient deficiencies. On the disease-related side, disease-related malnutrition is another driver, and chronic conditions like celiac disease, inflammatory bowel disease, or respiratory or neurological disorders may have higher nutritional requirements or malabsorption issues. And finally, looking at behaviour, we're thinking here about avoidant or restrictive food intake disorder, or ARFID. This isn't, as we said before, normal fussiness seen in children. ARFID is a formally recognised clinical diagnosis in the DSM-5, and it's characterised by persistent food avoidance or restriction that leads to nutritional deficiency, faltering growth, or a reliance on supplements. Children with ARFID might avoid food due to intense sensory sensitivities, fear of choking or vomiting, or simply a low interest in eating, and safe management calls for a multidisciplinary approach.
And more broadly speaking, Hannah says to prioritize food-first strategies wherever possible to manage malnutrition. Small, frequent, energy-dense and nutrient-dense meals and snacks should be encouraged, and fortified foods should be appropriately used where possible. Oral nutritional supplements should only be used to bridge the gap as a first-line strategy.
So moving on, let's talk about faltering growth, which replaces the older term failure to thrive. It's defined as a slower rate of weight and height gain than expected for the child's age and sex. To assess faltering growth, the weight, length for children under 2 and height for those over 2 should be plotted on the UK WHO growth charts after correcting for gestational age in premature babies. So what are some red flags for faltering growth?
There are specific thresholds that raise a red flag according to NICE and the Royal College of Paediatrics and Child Health. These thresholds depend on the child's birth weight. If the birth weight was below the 9th centile, a fall across 1 centile is a concern. If the birth weight was between the 9th and 91st centiles, a fall across 2 or more weight centiles would be a concern. And if the birth weight was above the 91st centile, a fall across 3 or more weight centiles would be a cause for concern.
So that makes sense. A child whose weight is below the 2nd centile would be an immediate red flag, regardless of the birth weight. And a child over 2 years old with a BMI below the 2nd centile would be a major concern for faltering growth. So what might be some of the medical differentials for faltering growth?
Medical differentials for faltering growth are extensive. They include inadequate oral intake due to weaning issues, ineffective bottle feeding, or breast problems like mastitis. Medical conditions in the child could also contribute and range from GORD, cystic fibrosis, and cow's milk protein allergy to inborn errors of metabolism, thyroid disease, or chronic infections like HIV and TB. Clinicians must also rule out anatomical issues like pyloric stenosis, cleft palate, or congenital heart disease, as well as childhood syndromes like Turner or Down syndrome. A detailed list of differentials can be found in the module. Investigations according to the module can include FBC, UNEs, CRP, LFTs, glucose, tissue transglutaminase antibodies and thyroid stimulating hormone, chest X-ray, urine dipstick, and stool sample. The module cautions against over-investigating and states that watchful waiting and health visitor support may be appropriate in some instances.
Yes, and in the module, Hannah also discusses child protection issues to consider in a child with faltering growth. Apparently the management is varied and it'll largely depend on the history and examination and should also take into account parental concern. I think you spoke to Dr. Joy Shatlock about this issue in general, didn't you, Sangeeta?
Yes, I did. She's the RCGP safeguarding lead, and she discusses child protection and safeguarding in detail in one of our previous episodes. It was pretty informative, and she goes into how GPs can identify abuse and neglect to stop and to prevent escalation. And she discusses the core principles of the RCGP safeguarding standards and the GP's role and professional responsibilities in safeguarding children from abuse and neglect. So I highly recommend listening to it. We'll add a link to it in the notes for this episode. So, what have we learned today? First, GOR can affect older children too, and the presentation is quite different than that in infants. Older children might complain of dyspepsia, retrosternal pain, or epigastric pain. The condition is less likely to be self-limiting in older children, so clinicians have to watch out for longer-term consequences like recurrent aspiration pneumonia and dental erosions. Second, childhood malnutrition in the UK often occurs without obvious wasting, driven by ultra-processed foods and restrictive diets, and it can even be seen in children with obesity. Management must heavily prioritize a food-first approach before turning to supplements. And third, faltering growth is defined by specific trends across growth centiles based on birth weight, and investigations and management can be varied depending on history, examination, and parental concern. Clinicians should also consider child protection issues in a child with faltering growth. Thank you, Pat. And thanks to all listeners for joining us today. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Don't forget, you can claim a CPD certificate for listening to this episode. Simply head over to the website version at mimslearning.co.uk. Next week's episode will continue with the theme of infant feeding, but with a focus on medication and breastfeeding, with MIMS Learning's Deputy Editor Rhiannon and pharmacist Rachel Pilgrim. See you next time.